Οπότε έχουμε τη δεύτερη ομιλία της κυρίας Vidmar, η οποία αφορά role of electrophysiology in the diagnosis of LHON.
Dear ladies and gentlemen, I will tell you about the electrophysiology in LHON. As your professor already said, the patients can be men, also women, from 6 to 81 years of age. These were the youngest and the oldest published in the literature. The average is from 27 to 34 years of age. And you should be aware that maybe patients that go around with the diagnosis of bilateral painless optic neuritis are in fact LHON patients. The diagnosis is primarily clinical, and we have to see the patients in the acute phase. First, they lose vision in one eye, and later, in 2 to 4 months, the disease progresses also to the other side. Why is such a long way to diagnosis? Patients may have completely normal fundus in the beginning. They may be referred to a variety of different specialists before they come to neuro-ophthalmology department and to electrophysiology lab where LHON is finally suspected. In 90% of cases, we have these 3 typical mutations, but in Slovenia we did a study where, in the contrary, only 2 out of 8 of our patients had these typical mutations. So we had a really different genetical picture than the rest of Europe. It was already explained why ganglion cells are especially have such a higher energy demand, and even we saw a video about that. The new things about LHON is that it was divided to subacute and dynamic phase. The subacute is less than 6 months when they lose vision, and dynamic is from 6 to 12 months. And here we have this typical clinical picture with central scotoma, poor visual acuity, impairment of color vision, and we see the typical fundus changes with papilla, with hyperemia of the optic discs. This is the fluorescein angiography. In late phases, there is never leakage from these discs. And typically, there is no pain on eye movement in contrast to optic neuritis. MRI is normal, and here again, how we diagnose these patients. Electrophysiology, it's an important test together with genetic testing that confirms the diagnosis. You have to think about other optic neuropathies. This is a subacute vision loss, so it might be LHON if it's inherited, or it might be toxic or nutritional causes. We did a study that was published 3 years ago. None of our patients at that time got idebenone because we didn't have these typical mutations and we couldn't get the drug. The age at presentation was from 11 to 30 years. They were counting fingers to 0.3. MRI was normal, and they all had this central scotoma. This is how the fluorescein angiography looks in late stages. It was explained about OCT in LHON patients that in the unaffected carriers we have retinal nerve fiber layer swelling, but later on what we see in the first 4 months is loss of the ganglion cells. So here it's normal, and here we see a loss of ganglion cell and loss of inner plexiform layer. So this is a very important sign of early disease. Later on we have retinal nerve fiber layer loss. These are our patients. 5 months after the vision loss, you see just temporal pallor, and later on much bigger pallor. Why is it important? Because a big study was done by Balducci at co-workers where they studied this ganglion cell loss, and they found that it's most prominent in the first 6 months in the acute stage of the disease. Now the topic that I should explain, it's about electrophysiology. In LHON, the most important tests that I already shown you before are pattern ERG and VP, but there were also studies with multifocal ERG and studies with photopic negative response. The literature is relatively scarce. The problem of this literature is that most of the studies were done in already chronic state, so after the first 6 months, and there is no real study in the acute stage. I already explained that P50 response shows the macular function, whereas N95 the function of the ganglion cells. And we also record VEP. Graham Holder published a case that had absent N95. Here it's a normal pattern ERG response, but in his patients in 2 eyes there is no 95 response, but there was already bilateral disc pallor, so this was advanced disease, and there was abnormal VEP. We had a patient, 11-year-old boy, that lost his vision 2 weeks before, and we see that vision was hand movements on the right eye and 0.3 on the left eye. This was his visual field, and on the right eye we already see absent N95 response. Here there is a remnant of it, but after 5 months in both eyes we see no N95 response anymore, and we see bilateral optic disc pallor. Still, here the discs are still hyperemic. This is his cousin. He also was admitted. First we thought this is an optic neuropathy, but later he lost vision also in his other eye. This is his visual fields, and again N95 response is gone. So this is an early indicator of disease, and also VEP responses are abnormal. In the literature, it was mentioned that it's very important to compare N95 with P50. Normally N95 is much bigger than P50, but with LHON N95 is lost, so this ratio gets, normally it's more than 1, but in LHON patients it's less than 1. And VEP goes delayed, and there is lower amplitude of VEP. As I said, Holder published a study where just a few of these patients were really LHON. These were just optic atrophies, bilateral, and you see here it's this ratio where it's still normal, N95 versus P50, and most of these patients were in the lower half. However, these were advanced stages. Mayander and co-workers published a study last year. Here they had 12 LHON patients. They did it with a standard pattern ERG and with a bigger field. And again, all the patients are below in the lower quadrant. In our study, we used 30-degree pattern ERG, and we saw reduced PERC response in half of the patients already when the optic discs were still hyperemic. So this is a case with hyperemic optic discs and already no N95, 3 weeks after the onset of disease, and VEP was also abnormal. So we think that this was not yet published, but we think that with time, so here is 3 months and 6 months after the vision loss, we get from the normal N95 P50 ratio down to the abnormal values. So we think that the N95 response is an early indicator of that disease. And it is also in concordance with the OCT studies that in first 6 months most ganglion cells are lost. And here we find that our patients are in the abnormal region. I will not talk about multifocal ERG and photopic negative response because these were just rare studies. Don't get afraid of these busy slides so late in the evening. I just want to mention that you see here we didn't have no mutations. Just 2 of them had typical mutation. First, we didn't believe our results. We repeated with 2 different genetics clinics, but somehow we are different than the rest of Western Europe. Now similar results are seen also in some other countries. We are Slavic origin, so maybe we have some other genes than the rest of Europe. So we had to do Sanger sequencing, but then also next generation sequencing. And we really had problems obtaining the Benone because at that time it was just registered for these 3 mutations. This is one of our typical families with now this mutation was published by Kareli, but at that time we found it, no one else had this mutation. This is the grandmother that lost vision due to bilateral so-called neuritis, but it was LHON in her case as well. And these are two grandchildren that lost vision, one at the age of 11 and the other age of 20 years. This is the development of optic disc pallor. And the problem is usually you see patients already in the chronic stage where optic discs are pale and you don't know about the acute onset. Electrophysiology is very important, also showing the prognosis of the disease. Usually the prognosis is not good, but in some mutations, for example this one, the vision may recover by itself. So it's like from 37 to 60% visual recovery without Idebenone, so just a natural progression of the disease. Additional positive factors are earlier age of onset, larger disc, and subacute presentation. And I will show here 2 our patients that lost vision. Here 10 months after vision loss, the visual fields look completely black, but later there are fenestrations in this visual field, and the vision improved back to 0.5 and 0.8, and even we got some improvement of VEP latency and amplitude. This other case has a typical LHON mutation that is typical for good vision recovery. He recovered, but no changes on electrophysiology. So why is it important to diagnose this disease early? As your professor mentioned, it's just this window of opportunity when we can start the treatment. So it's the best to start the treatment before 1 year is gone to maximize the response. And to conclude, electrophysiology is a very valuable tool. We think that N95 of pattern ERG is a very important indicator of early disease, and that VEP waves are also abnormal. In our study, half of our patients had abnormal N95 when the discs were still hyperemic. In patients with visual recovery, OCT will show no improvement because the ganglion cells are absent and they won't be built new. So here, electrophysiology, VEP, is the best judge for visual recovery. I would like to thank you all for your kind attention.
Thank you, Martina.